Good afternoon. We are so excited to welcome you all to an inspirational and educational episode of Concorde Conversations. Concorde Conversations is an initiative by Concorde Medical Group to educate, empower, and encourage our community about our health so we can all live to our fullest potential. Today's episode is Stop the Spin, a discussion about dizziness, vertigo, and imbalance. Hi, I'm Dr. Catherine Weinberg, Director of the Adult Congenital Heart Disease Program at Concorde Medical Group, Northwell Health. We are joined by two outstanding colleagues from Northwell Health and faculty of the Zucker School of Medicine at Hofstra University. I would like to introduce you all to amazing internist, Dr. Danielle Silvershein, and neurologist, Dr. Danielle Torres. Both are board-certified physicians. Many of our Concorde community have submitted fascinating questions for them to answer today. If you have any additional questions, please ask them in the chat box. We only have 30 minutes together, so we will go through as many as we can. Remember, we are giving general guidance. If you have a particular question about your health, we'd like to help you. So come in and talk to one of our exceptional Northwell physicians so we can answer your questions and give your health the attention it deserves. So let's get started. What's the difference between dizziness, lightheadedness, vertigo, and imbalance?
So when we look at the different states, what we're looking at is the quality of your symptoms. If the room is spinning, we tend to term that vertigo, and that usually implies something wrong with your balance center. If you're dizzy, sometimes or imbalanced, imbalance usually means that there's a neurologic component to it. So we look at the neurologic aspects of dizziness. If you feel faint, then we actually get concerned that there's a cardiac issue. And then there's a whole miscellaneous thing where we lump that into just dizziness or lightheadedness, which is vague and can imply a whole host of things, metabolic, even psychiatric issues. But as an internist, our job is to sort of classify what is going on and try to get you to the right place. And even though there's some overlap between these things, right, the terms are kind of vague. We want to move you in the right direction as quickly as possible. So how people interpret this is how we move generally, the quality of your symptoms.
Yeah, and I think, one of the really hard things about dizziness is that it's hard to know exactly what to call things. And so that's why when we're seeing a patient for the first time, we're not just taking, I have vertigo and that's it. We actually have to understand more about it. And that's why we're going to have more questions about when it happens, how it happens, can you predict when it'll happen, how long does it happen? Because it turns out those other features actually really help understand a lot about these conditions.
Dr. Torres, how can you tell if the dizziness is from something mild like benign positional vertigo or something more serious like a cardiac condition or a stroke?
Right. So it's not always easy to tell, first of all, but it's interesting that often the more benign ones, the ones that aren't going to lead, that aren't strokes, for example, or heart attacks, often feel even worse than the ones that are more serious. But really, the one that's most likely to truly be benign without seeing a doctor is where just your position change causes symptoms that are brief. And that usually is not going to be something like a stroke or a heart attack. But it really can be hard to tell. And that's why we have to ask about it to understand it completely.
Yeah, we have a saying, bad things generally don't get better. So if it gets better fairly quickly, we're a little less worried about what's going on.
Dr. Torres, what are red flags? When should I go to the hospital and see a physician immediately?
Right. So the two most serious kinds of vertigo or dizziness are gonna come from stroke, or heart attacks can make you dizzy also. And so the biggest red flags are when you have symptoms other than the dizziness that are coming at the same time as the dizziness. So many of you might have heard of the FAST acronym for stroke, with face, arm, speech, and time. And the time refers to how quickly that it needs to be treated quickly. But if you're noticing things that are beyond dizziness, like your face is weak or a body part is weak, really, if you're falling down from the dizziness, it's really needs to be taken pretty seriously. And then along the lines of cardiac things, if this is coming with any symptoms that might go along with a heart attack, like chest pain, excessive sweating, difficulty breathing, those are going to be other big time red flags that, really shouldn't even be a phone call to your doctor. Those are calling 911 and going to an emergency room in an ambulance.
Dr. Silvershein, can you expand on that? When do you refer to a neurologist and when do you refer to a cardiologist for dizziness?
As Dr. Torres said, it's really about the severity of your symptoms, right? If you have something that's very clear cut, right? If I turn my head to the left and I start to feel the room spinning, we can usually identify that as peripheral vertigo. If it extinguishes, if it goes away within a minute, again, that's another sign. When we do our exam, if we see something that's out of the ordinary, we see a neurologic sign that's not consistent with typical vertigo. If we see a change on your EKG, if you're feeling palpitations or they're not going away, or there's something abnormal about your story, then it's our job to identify, is this neurologic, is this cardiac, and move on. So usually with neurologists, if you have a focal neurologic symptom, if the plane of your dizziness is not something that's expected, if it's lasting more than a minute, meaning that your brain's not recovering the way it should, then we'll send to a neurologist. For the cardiologist, in many ways, it's more like a faint. So if you feel something sudden and coming on and very severe, as if you're going to pass out, or even if you do pass out, that's much more consistent with an irregular heart rhythm, and that's something you send to a cardiologist.
Yeah, I think to add to that, even if what's going on seems to be benign, that doesn't mean that it's good to have. And, these dizziness problems can make you extremely uncomfortable and affect your quality of life. So even if it seems totally clear cut, like this isn't a stroke and you're going to be okay, if you're not improving within a few weeks, it's helpful. You should go see a neurologist to evaluate you, because even the benign things do have treatment. And so you don't need to suffer with the problem, even if it's not going to kill you.
And cardiac disease has treatment as well. So come see us at the office. All right, Dr. Torres, why are dizzy episodes so erratic?
Some dizzy episodes are erratic. So actually, the fact that a dizzy episode is erratic is actually one feature that helps me understand what it might be. So in terms of that question, the answer is that it depends on what the dizziness is caused by. And really, when you're seeing things that are more erratic, it makes us think of things like migraine, which we don't always clearly have a trigger of. Things like arrhythmia, where your heart is having an abnormal heart rhythm and you're not getting normal blood flow to your brain, can be very erratic. And things like Meniere's disease, which is another neurological cause of vertigo, can seem kind of erratic.
Okay, Dr. Torres, what is benign positional vertigo? What causes it?
So benign positional vertigo is the most common kind of vertigo that people get. And it's an unusual condition where there really isn't any imaging test that's going to be done to diagnose this. What it's caused by is that you have these little semicircular canals inside your inner ears. They hold fluid in them. And the movement of that fluid activates neurons and tells your brain how you're moving at any given time. We all have those canals. And in benign positional vertigo, what's happening is that you're having little crystal deposits that get stuck in the canals. And basically the fluid doesn't move freely the way it does when you don't have the crystals, or you can think of it, the viscosity of the fluid is kind of different. And so your movement is going to produce different fluid movements. And it typically happens on one side. So you get into a situation where one of the ears is detecting movement in one way and the other inner ear is detecting movement in another way. And so you start having an illusion of movement, which is what the vertigo is.
Yeah, I always tell my patients, I describe it to them as if you've ever seen a carpenter's level. It's basically a tube of fluid with a bubble in it. And as you tilt the level, the bubble shifts in space. So imagine you have these levels in your ears, in your vestibular apparatus. And when you turn your head, one bubble is just shifting slower than the other. And so your brain wants peace. Your brain wants to hear the same opinion from all the input, your eyes, your ears, even your feet where you're sitting. And when there's disagreement, your brain doesn't always know what to do with it. But if your brain functions normally, it will tamp down the abnormal signal, usually relatively quickly, within a minute.
Okay, Dr. Silvershein, why do I mainly get vertigo when I lay down? Is there a reason for this?
Well, remember, you have these canals as Dr. Torres described, and these canals are in different planes. So if the canal that is affected is in the plane that is, sort of the horizontal plane, as you come backwards, that's when the bubble is not shifting correctly, right? In that case, if you turn in other directions, you might not get, that bubble might not need to shift. And so you will not experience vertigo unless you make the right move.
And the reason lying down is the most common provoking factor for BPPV that we just discussed, because the canal there are three canals, and the posterior canal is the one that it happens the most to, and it's because of the anatomy of the inner ear. And so that is the most common way that people get it. And it's often actually laying down with your head slightly tilted to the side is the major provoking factor, but you could feel it with your head in any position also.
Right. And when we test people for benign positional vertigo, that's exactly what we do. We lay them back and we turn their head to the side. And then if we induce vertigo, now we've made the diagnosis.
Right. We're looking for some very specific signs on their eyes that tell us that that canal is dysfunctional. And so this condition is interesting because as a patient, the doctor actually has to make you feel sick in order to make the diagnosis. And then we do another maneuver that actually is what fixes it. So this is one of those conditions where there's going to be some vertigo to achieve the cure to it as well, which, great for patients. The cure isn't, take a medicine for prolonged periods of time. It is this specific maneuver that really can totally cure the problem.
All right, great. What is Meniere's disease, Dr. Torres, and how do you treat it?
So we're not sure of the cause of Meniere's disease, the root cause of it. A lot of people think that it's probably an autoimmune condition. But what's happening is that fluid is building up in the inner ear. So this is part of the ear that you can't see when you look in someone's ear. It's behind their eardrum. And the fluid that is in there is putting pressure on the structures that sense movement. And it also is putting pressure on the structures that hear, which is the cochlea. And so with Meniere's disease, what's happening is that you'll get vertigo, but frequently along with auditory symptoms. And the most common symptom is going to be feeling like you're kind of underwater in that ear, like a muffled sound. And really, when people have hearing test that shows that they have a low frequency hearing loss, meaning that low pitches are ones they can't hear compared to high pitches, that is actually one of the ways that helps us diagnose Meniere's disease. And the other big thing about Meniere's disease is, unlike BPV, it's not something that only makes you dizzy when you go into a certain position. Meniere's disease comes in these long episodes that can be hours to days. And yes, when you move, you're going to feel worse than when you're still. But patients with Meniere's don't feel okay when they're still either. And they just feel much worse when they move. And then we look for that hearing problem to go along with it. But sometimes it can be hard to tell because Meniere's vertigo that's from Meniere's disease also can look a lot like migraine, which is another cause of vertigo. And so often I'm asking this question of myself: do I think you have that or migraine?
Dr. Torres, can severe vertigo affect my vision?
So the way that vertigo affects your vision isn't really through the function of what your eyes can see or through the occipital part of the brain where we see that helps us understand what we're seeing. The reason that vertigo can affect your vision is that at all times, our inner ears that are sensing our movement are actually very tightly coordinated with our eye movements. This is extremely important for everything we do. The reason that I can kind of nod my head and keep looking at you and not feel ill is that my eyes are moving with my head when I move. I don't have to think about that. It's an unconscious thing. It's a connection. So if you have vertigo, your ability to do that is going to be interfered with because you're not getting appropriate information about how you're moving, which then means that your eyes aren't going to be able to adjust to that movement well. And so a lot of people can feel very abnormal in their eyes, but the truth is their eyes work fine and their brain works fine. It's that they're getting bad movement.
It's the same as becoming seasick, right? So when you're on a boat and you're staring out at the horizon, your eyes think that everything is staying level, but your feet are actually moving underneath you. And so again, if anytime you get this information that's not consistent, you'll start to feel sick. You'll start to feel symptoms. Motion sickness is just a variant of this type of vertigo.
Okay, Dr. Silvershein, does stress or dehydration contribute to dizziness?
Stress and dehydration contributes to everything. So certainly when you're stressed, when your body's stressed and your heart rate's going up and you have less circulating volume, it's going to change the way you perceive the world. And it's also going to change your blood pressure as you get up, as you sit down. And so that, more so than vertigo, it's going to make you feel more dizzy and more lightheaded, right? So, and because these things, they're not a function that your heart is not working properly, but it's an issue where your heart has to work harder to make things up. And sometimes your blood vessels are able to compensate and sometimes they're not. But as we become more stressed, and that again, both physical and emotional, we see changes in people's perception of where they are in space and dizziness.
Are there any over-the-counter medications that you can recommend?
Okay, so over-the-counter, in light of what we talked about with seasickness, some of the drugs that we use for seasickness, like meclizine or dramamine, are useful for vertigo. We used to think they affected the actual the semicircular canals, your hearing apparatus or your balance apparatus. But what we think they actually do now is they loosen up that connection between your ears and your eyes, right? So your ears, as Dr. Torres alluded to before, your ears and your eyes are very tightly connected, and that's what induces that vertigo. But if you can loosen that connection a little bit, you won't spin as violently as you could in the right situation. So that's how we think these drugs work. They are by no means perfect. They do have side effects. They do make you drowsy, but they're what we have for now. And in the short term, they can be useful for patients. But if you're going to go to the pharmacy and take something for vertigo, you probably should be seeing your doctor as well.
Yeah, we really use medications for something that we expect to be short-lived and the person get over easily. So seasickness is a great example of that. You're not going to be sick when you get off the boat. But if you have something that's going on for a while, really the medicines are just dulling the symptoms of the vertigo. They're not actually helping someone recover from the vertigo. And it also depends what the causes are, right? So if you have an inflammation in the inner ear, which we call vestibular neuritis or labyrinthitis, they'll help calm down the symptoms, but your brain also needs to adjust to the inflammation that's there. And actually, there's some studies that show that using these medications regularly might slow down your ability to recover. So we really think of medications for people that are too sick to do anything, where the vertigo is so intense that you're really unable to get out of bed, unable to function. You don't need to feel terrible, and so we use them in those cases. But in terms of the overall trajectory of treating these problems, we actually are trying to get people off of medication. And the other thing that's worth mentioning is that there is a fair amount of vertigo that is caused by migraines. And so in people who have had migraines and are having sort of attacks of vertigo for no good reason, even if they don't have a headache, sometimes migraine medicines actually can completely get rid of the vertigo.
Okay, so let's talk about other ways to treat vertigo. What are Epley maneuvers and do they help?
Yeah, so this is the curative maneuver that I was referring to earlier. So once we lay the patient down to diagnose their BPV, and you can tell that which ear it's on, then you go and you do an Epley maneuver. And this is a maneuver where you basically move the person's head into 3 different positions. And that's because Epley, whoever Epley was, figured out that when you move these positions, you actually can get the crystals to dislodge from inside the canal and dump into a different space and restore the normal flow of that fluid. And so it's understanding the anatomy and using that gravity forces things down. And so these positions get the crystals to move by using gravity, essentially.
It can be difficult for patients to endure the maneuver itself. So I think we just don't want to make enemies. That's probably why we don't do it. They're not that difficult to do, but they have to be done the right way by somebody who's really trained.
Yeah, doing it yourself is really hard. You know, there are some people that have BPV that comes back, and in those patients, I always am going to teach a family member how to do these maneuvers on them. I usually tell them not to do them themselves because the position, the angle of your head really needs to be right. You know, it needs to be accurate because the anatomy, the whole way it's designed requires gravity pushing the crystals in the right way. And so it's much easier for someone else to do the maneuver to you. And yeah, when people deal with this coming back, certainly it's something that they can learn. But usually we're the ones who start with it.
Okay, Dr. Silvershine, when do you recommend vestibular physical therapy? Does it help long-term?
I think vestibular physical therapy is actually one of the most important things that patients can do to treat their vertigo. And I'll recommend it for anybody who's had a persistent case or has had a recurring case. I think that what a vestibular physical therapist can really do is help you retrain your brain to process this information better. And they do it in a way that, there's no medication. It can be repeated by the patient as opposed to something like an Epley maneuver. A lot of what a vestibular rehab person will do can be repeated in your house. And so I think the information is really important. So I would say the majority of people who suffer from vertigo, I think they would benefit from vestibular rehab.
Yeah, and even with BPV, when I diagnose that, I'll do an Epley, and it's usually helpful. I'll usually also still send that person to a vestibular therapist because frequently you're going to need an Epley done 3, 4, 5, 6 times to sort of get all the crystals in the right place that they're supposed to be. And, it's hard to see people every day. And so this is a big benefit to have vestibular therapists who are well-trained to do those maneuvers. And so I send almost all my VPV patients to sort of finish out the whole thing with a vestibular therapist.
Okay. There's a question in the chat box. Can ringing in the ears induce vertigo or dizziness? How is it associated with it?
Dr. Torres had talked about Meniere's disease, right, where both the balance apparatus and the hearing apparatus, they're very similar organs. They're right next to each other. And even though they're not the same shape, their constitution is basically the same. So in people who have Meniere's, you will see vertigo associated with ringing of ears, with tinnitus. And if you do have tinnitus, it should be a reason for you to go see either a neurologist or an otolaryngologist to help make the diagnosis.
Yeah, I send most people to ENT who also have tinnitus, Meniere's, but also vestibular neuritis is another condition that can cause ringing in your ears. And I wouldn't really think of the tinnitus as a cause of the dizziness. It's more that what's causing the dizziness is also causing the tinnitus. The last thing to say about it is that many people have ringing in their ears. So in a lot of cases, they're totally unrelated.
Okay, Dr. Torres, you're an expert in concussions. How often does dizziness occur after a concussion? And what can I do to help my symptoms?
Dizziness is really one of the top 3 symptoms that happens after a concussion. And in the immediate time of the concussion, even before concussion was something that was known by a lot of people, we all saw cartoons with spinning birds above people's heads, when that they're dizzy after they hit their head. So it's super common. But then the question of what do you do about it is actually harder, because these head injuries can actually cause almost every single kind of vertigo. So head injuries can cause BPV because you can actually rattle the inner ear and dislodge the crystals in the inner ear. Head injuries often cause neck problems. And actually, some people with neck problems get dizzy due to their neck problems. Head injuries cause migraines, which can make people dizzy. Head injuries can also cause autonomic nervous system problems, where your heart sometimes races out of proportion to what you're trying to do. And this is a condition called POTS, or postural orthostatic tachycardia syndrome. And the most frequent way that people describe that what they're having, which is the tachycardia, is often dizziness, is actually the most common way that people will talk about it. So really, it depends in terms of the treatment. And that's why it's helpful to have someone who is fluent in all the things that can happen with concussion. And that's not only neurologists. There are a lot of great internists that are fluent with these things as well, to sort of get to the bottom of, in your case, in your concussion, what is the thing that's doing it? Because if you're trying to treat BPV with migraine medicine, it's not going to work, and vice versa.
Okay, Dr. Torres, a patient stated they had vertigo every day for 12 years. It was sudden onset, no injury or illness preceding it. No diagnosis has been given despite extensive testing. How can they find answers?
Right. So hearing the question, obviously, I don't know everything about this person, but there is a well-described phenomenon where someone has an attack of any kind of vertigo. So that can include neuronitis or BPV, Meniere's disease, even migraine. But they get an attack and they just never recover. Now, what does recover is that there are often physical exam findings when someone has a sudden onset of vertigo. And typically those physical exam findings will go away. But the person basically just doesn't adapt well to whatever the vertigo was, and they continue to have symptoms over time. Typically, people who have this problem experiencing vertigo all the time also develop a increased level of anxiety about everything, including the vertigo, for them. And so often, in addition to the vestibular problem, there's also more anxiety in general. And the condition is called persistent postural perceptual dizziness. And really, it's well described now. So you actually don't need a test to diagnose this. All the tests are going to exclude other problems, which are like stroke and all the things that we're discussing. But the test being negative doesn't mean that you can't have PPPD. In fact, that is probably what this person has. And the treatment of it is really a combination of having a very good physical therapist that's knowledgeable about this, having a psychologist who is knowledgeable about this condition, because like I said, it's a problem of brain adaptation. And, psychologists can help put your mind in a frame to adapt better. General healthy lifestyle things make a big impact on this. And also sometimes we use medications to just keep symptoms a little bit lower while they're trying to recover. And these are different medicines than what Dr. Silvershein and I were referencing before. But it's a really hard problem to have and deal with, but it actually is treatable. And so it's well described in literature now. These treatment protocols actually have been well studied. And so, whoever asked the question, other people in that situation, there really is a path forward from getting better from it. And you really should see someone who knows about that problem and try to get treated.
Dr. Silvershein, dizziness is a common side effect from medication. How do I know if my dizziness is from medication or from something else?
Well, certainly the timing of the dizziness is always important. So if you wake up in the morning and you take, let's just say, your blood pressure medication, and then 30 minutes later you start to feel dizzy or lightheaded, certainly that's probably going to be the medication. From my perspective, we always look at what's new, what's changed, and what's changed in your life that might be related to that. So Again, taking the blood pressure medication as an example, if you lost a lot of weight and maybe your blood pressure now has come down, you're going to start to feel dizzy when you're taking these medications. So this is something that usually a good history will bring out. And a lot of times, just even a simple physical exam will help us. But we like to associate that with when you take the medications themselves.
Okay, last question. Dr. Torres, if you had one action step to recommend to our viewers to improve their health and start today, what would it be?
So, in my practice, I've done a lot of brain injury. I treat a lot of people with brain injury, among other neurological issues. And from what patients tell me, the suggestion that I've made that's made the biggest difference in their lives has actually been adopting a mindfulness meditation practice. And that's sort of not just the Shavasana at the end of a yoga, but really, a practice where you're sitting down, focusing, getting distracted, refocusing, and really practicing your focus. Really, it turns out, has widespread benefits and is actually an effective treatment for a number of medical conditions now, we know, since there have actually been good studies to demonstrate this. So I always say 5 minutes a day is infinity more than zero, and it doesn't have to be a massive commitment, but it can be a really difference maker.
Okay, Dr. Silvershein, what's your answer?
Well, so first to add on to his point, with the patient who had the persistent vertigo, that's something that your brain has learned, and it learns through repetition. And so what Dr. Torres is suggesting, which is true, is that when you teach your brain the right things, when you teach your brain to get rid of some of these adaptations, you're definitely going to be better. But in my practice, the most important thing I'll tell patients is get a good night's sleep. I think sleep is vitally important to both your cognitive function, it's important to your metabolic function, it's important to your cardiac function, and we often ignore it, right? It's something that we give up because we have other things intruding into our lives. And so we always say work smarter, not harder. But if you're not sleeping well, you're definitely working harder and you're not working smarter.
Thank you all for joining us for another inspirational and educational episode of Concorde Conversations. A very special thank you to Dr. Torres and Dr. Silvershein for joining our conversation. We appreciate their expertise to educate, encourage, and empower our community. And as part of the Concorde community, we hope you will share our mission with your friends and family. Please pass along our emails and webinar links. In addition, please like and subscribe to our YouTube channel. Finally, please fill out the survey at the end of our program and let us know how we can serve your needs better. We know many of you have additional questions about your health, and we want to help you. So come in and speak with our extraordinary Northwell physicians about your health. We care about your health. We care about you. Thank you so much for joining us today.